صعب قوي العالم يستمر في الوضع ده يا فندم.
الوضع لا يستمر ده هيبقى كساد عالمي زي الكساد بتاع سنه 1930 والحاجات
1929 الكساد العالمي ما هو ده اللي حاصل اوريدي. يعني الحمد لله ان احنا في مصر برضو يعني ايكونوميكالي يعني ما تاثرنا، يعني الى حد كبير ما تاثرناش كتير.
لا بس قطاع السياحه عندك في شرم الشيخ والغردقه
تعب بس ستيل انا كنت لسه هناك، يعني ستيل لسه فيه يعني اعتقد مثلا قطاع السياحه في انجلترا قافله خالص، يعني اعتقد ان هو قافل تماما.
هو مين بيروح انجلترا سياحه يعني؟
يعني مش كتير يعني
حلاوه
فعلا ما
الجو
فيهاش سياحه كتير.
يعني اللي عايش
لا
في
بس الغردقه وشرم الطيران الروسي فتح معاهم يا فندم،
اما
فده
الروس دول
اعتقد
قلبهم جامد.
لا هينعش الموضوع شويه، ربنا يسهل.
بس هو السياحه الروسيه يعني انت لما بتعرف ناس من الوسط لا السياحه الروسيه مش اللي
هي
عليها العين يعني.
لو كواليتي
يعني مش عايزين نقول كده احسن يكون حد سمعنا
لا مش لو كواليتي في الناس، لو كواليتي في الصرف.
ايوه
في الصرف، لا مش قصدي انا قصدي في الصرف
ما
ان
انا
هم
فاهم قصدك،
الروس عموما ما بيصرفوش كتير في السياحه،
لا
عكس
هم
مثلا
طبعا
الالمان الانجليز، لا دول سياحه
الالمان
عاليه قويه.
فاكهه السياحه المان.
بالظبط، الالمان طبعا الالمان لا بيصرفوا.
اه
انا رحت مره حضرتك، كنت في هاواي، رحت هاواي مرتين. فالسياحه في هاواي عباره عن كنديين ويابانيين وساوث كوريين. طبعا دول بيصرفوا كتير يعني، كتير يعني.
احنا بنصرف برضه بس على المسحات.
ربنا يسترها يا فندم ويعديها على خير.
بعديها على خير.
احنا قدامنا حضرتك دقيقتين ونبتدي يا فندم.
قوي لو عايز تبتدي
اقدم سعادتك يا فندم. بسم الله الرحمن الرحيم. النهارده يسعدنا ويشرفنا جزيل السعاده وعظيم الشرف ان يكون معانا يعني استاذ كبير واخ عزيز فاضل، بروفيسور ايمن سوريال، دكتور ايمن سوريال فروم يو كي. دكتور ايمن محاضر مبدع، محاضر عظيم، كل محاضراته اللي شرفنا بيه قبل كده يعني لاقت قبول شديد من قبل حضراتكم، وعلى اليوتيوب شانل ما شاء الله الفيوز بتاع دكتور ايمن يعني في التوب ليفل يعني. فاحنا طبعا بنشكر دكتور ايمن بيه سوريال ان هو قطعنا اجازته السريعه في القاهره، وان هو شرفنا بالمحاضره الرائعه اللي هنسمعها من حضرته النهارده يا فندم. Thank you so much sir for joining us tonight.
انا متشكر جدا يا دكتور محمد، واحنا بنشكر الدكتور محمد الاشهب ان هو جمعنا في هذا يعني انجاز عظيم بيجمع الناس من الشرق والغرب، وانا دايما يسعدني المساهمه معاه، ده شرف لينا. والنهارده المحاضره ليها طعم خاص ان انا في قاهره المعز وفي ارض الوطن، والمحاضره دي اتحضرت على عجاله، فسامحوني ان انا ما قدرتش ان انا احط فيها كل ما كنت احب، لكن ان شاء الله يبقى فيه استفاده منها. نبتدي يا دكتور محمد.
اتفضل سعاده الباشا، اتفضل دكتور ايمن بيه.
We're going to talk today about an unusual topic. The topic is soft tissue injuries of the hip joint. Now, before I say anything, if we start talking about soft tissue injuries, if we say the knee, then everyone knows what I'm going to talk about. We're going to talk about the collateral ligament injuries, talk about ACL, PCL. If we're talking about soft tissues of the shoulder, then everyone will start talking or considering we're going to talk about the rotator cuff of the shoulder. These are joints that are famous for their soft tissue injuries, and the hip is not particularly famous for soft tissue injuries. It's famous for fractures in the elderly, it's famous for arthritis, and these are very important topics, but we will not talk about these particular topics. We're going to talk about patients presenting with hip pain. Hip pain is classically in the groin, but hip pain can also be on the lateral aspect and the buttock. Classically is what we call a C-type pattern. It goes around the hip from front to back. We're going to talk about patients with possible traumatic etiologies. So these patients have had an injury, whether it's one injury where they're presenting with the injury, or they had an injury in the past and they have ongoing symptoms, or they have repeated injuries. Most importantly, all the patients we're going to talk about today will have a plain radiograph that looks like this, that there's no obvious pathology, no obvious fractures. Now, I have worked in a unit where I've done a fellowship, the Royal College Approved Fellowship, which I'm very proud of. I was the first to be given the certificate, first ever to be given the certificate in a formal ceremony. I was very proud of this, and the whole year I spent in that particular study and this particular work was seeing patients that had no particular obvious pathology on a plain X-ray, but they had hip pain. Let's talk a little bit about the hip joint. We're not going to talk in depth about the anatomy and different things, but we're going to talk about the hip joint in terms of anatomy. We've got a very stable joint with a very deep socket that's normally very congruent with the femoral head containing the hemispherical head, and therefore is very stable. It also has a labrum that deepens the socket and therefore adds to the stability, which is even enhanced by a ligament that goes from the socket to the valve around ligament, and this helps with the stability. Other factors, there are many other factors of the stability. We're going to talk about the ligaments. There's a very strong iliofemoral ligament, what's called the ligament of Bigelow. It's inverted Y, and it has a broad insertion, and it's a very strong ligament, and this ligament helps to prevent hyperextension of the joint and prevents anterior subluxation of the femoral head. We've got the pubofemoral ligament, arises from the pubis, inserts along the same line, the trochanteric line. And as you can see, as these two ligaments check the movement here, you can easily understand where fractures happen in the elderly, the trochanteric fractures. We've got the ischiofemoral ligament, and the ischiofemoral ligament winds around the posterior aspect and prevents excessive rotation of the hip joint. The muscles of the hip, I think the hip is one of the most generously covered with muscles. It's a deep joint. We've got layers and layers and layers of muscles. We've got the gluteus maximus, which is a very powerful extensor of the hip. Gluteus maximus have got two insertions. There's a superficial insertion, which blends with the tensor fasciae lata into the iliotibial band, which goes beyond the hip and beyond the knee to insert in Gerdy's tubercle in the proximal tibia. We've got the gluteus medius and minimus, and gluteus medius is, in my opinion, many other surgeons' opinion, is the key muscle to the hip. It's one of the main abductors of the hip. It's the main stabilizers of the hip with the hip replacement together with the gluteus minimus. We're going to talk in detail about the insertion of both later in this talk. We've got the short external rotators, which is very important muscles. Anyone who does the posterior approach to the hip knows the piriformis, the obturator internus, and the gemelli. This is the muscles that are detached of the posterior aspect to gain access to the posterior aspect of the hip. We've got the iliopsoas, a very powerful hip flexor. We've got the reflected head of the quadriceps femoris. Again, with the posterior approach, this is the muscle that we quite often release to translate the femur anteriorly to gain access into the acetabulum. We've got the hamstrings, we've got the adductors, we've got the sartorius arising from the anterior superior iliac spine and the pectineus. How to assess a patient with a hip injury? As any other injury, we assess the history, mechanism of injury, what type of fall, what type of injury was the patient able to weight bear afterwards, and how is he presenting? How soon after the injury did he present? Is he presenting with pain? When it comes to pain, pain is not just pain. Pain is pain intensity, pain character. You can always ask the patient about the visual analog scores. Is the patient's pain 0? Is it 10? Does he limp? Does he have stiffness? Is his pain getting better or worse? A patient that is getting better says that my pain was 10 and now is 6. That patient is improving. You might consider waiting and seeing how he does. Onset course duration is one of the very first words we heard in medical school, and it remains a very important thing. Pain intensity and pain radiation. Is the pain coming from the hip? Is it coming from the spine? Is there another cause of pain? You have always to consider, is this pain coming from the hip or is it coming from somewhere else? Hip pain also classically goes to the knee, so bear that in mind. Assess the patient's gait. Patient's gait will tell you what's happening with this patient. An antalgic gait is classically a gait with shortened stance phase. You have to identify that. Trendelenburg gait is very important. Does the patient have abductor weakness? Then if the patient has got abductor weakness, is it because of the muscle? Is it because of pain? Is it because that he's got a neurological condition affecting the L5 root? I always examine a full neurological assessment for every hip pain, because you will never know what you're going to find. You might be surprised to find that you've got a patient with hyperreflexia, clonus. Something else is happening here. The pain is coming from somewhere else. You have to consider that. And then the concept of look, feel, and move. Inspection. The hip joint has got three surfaces. You have to see the anterior, the lateral, and the posterior aspect. You look for scars, look for wasting. You have to look at the hip in every possible way. You have to assess for deformity. Thomas test will tell you whether there is a fixed flexion deformity. It's very important. It's usually the case with arthritis, but you never know. Even with a soft tissue problem, you could have a contraction. Limb length difference. There's difference between the apparent and true limb length. Measure from the xiphisternum or from the umbilicus to the medial malleolus, or measuring from the anterior superior iliac spine. If there's shortening, you have to identify, is this shortening coming from the supratrochanteric area or from the rest of the femur, or the shortening coming from the tibia? That's very important. That's the basic examination. You have to assess the range of movement. Compare right to left and see what movement pain start. If you're doing maneuvers like flexion, adduction, turn rotation, called the Faddeer maneuver, then you have to consider that this is a very important thing. This could be a result of femoroacetabular impingement. Trochanteric pain and sacroiliac pain, ischial pain is also important. Now I'm going to start and talk about I've said before that we're talking about patients who doesn't have a fracture, but I'm going to start with patients with fractures. But nevertheless, there are patients with fractures. There's nothing to see on a plain radiograph. If you've got an elderly patient, considered an ankle fracture. Patient had a fall, patient is unable to weight bear, then there's a possibility this patient has got a fracture, particularly if the patient is unable to weight bear. If that's the case, you can consider and you can pick up something that looks like this, orthogonal views, AP and lateral views. And on the T1, you can see a fracture there, and then you start treating them as a fracture. You can sometimes see patients with an X-ray like this. If patients got a trochanteric, a greater trochanter avulsion fracture, these are soft tissue injuries because that's the insertion of your abductors. But nevertheless, these seemingly innocent injuries can harbor a more important injury. Lee et al. In 2010 studied a series of 25 patients, found 20% chance of a trochanteric extension. So don't take them as just a GT fracture. Make sure that there is no underlying fracture. Bearing in mind that some people can advocate the fixation of a large trochanteric fracture. Nevertheless, the fixation of an isolated trochanteric fracture is particularly tricky. And the correct way of doing them is doing either a tension band or a GTR place. So bear in mind, these are not simple ones to treat. Stress fractures, I've seen many stress fractures in neck of femur patients, and these are very common with runners. Commonly not obvious on a plain radiograph. There's two types mainly. There's the compression type, where the fracture is extending into the inferior neck and not extending into superior neck, and the tension side. These are more critical. These tend to extend and result in a complete fracture. And the advice is for the tension types, if they're discovered on an MRI scan or a CT scan, is to fix them, to secure them, to prevent further propagation. Of course, there's the athletic avulsion fracture. These are normally very fit, very young, very strong patients, and the muscle contraction pulls part of their insertion. The abdominal muscles can detach part of the iliac crest. The sartorius can detach part of the anterior superior iliac spine. The reflected head of the femur can detach part of the anterior inferior iliac spine. The abductors can detach the gluteus medius, minimus, and the iliopsoas, the same with the lesser trochanter. The ischial tubercle is particularly important in sprinters and runners, can have an avulsion fracture of the hamstring origin or even the adductor tubercle. Now, we've talked about fractures enough. Let's talk about the main topic of this. This is the femoroacetabular impingement and other causes of hip pain that are not related to fracture or arthritis. So what is femoroacetabular impingement? It's defined as a pathological mechanical process by which there is repetitive trauma and collisions between the acetabulum and the head-neck junction that results in soft tissue damage. And the damage is likely to be the labrum with the adjoining part of the articular cartilage lateral to the source. There's mainly two types. There's a cam lesion when there is an elevation of the head-neck junction, most likely superior, but more importantly anterior, because the pain is generated by internal rotation. There's also the pincer type of deformity, where the deformity is actually an oversized acetabulum with the elevation pushing the labrum into harm's way. There's a reason why patients have these deformities and have no pain for a long time. Before, at one point, one particular movement or particular injury, then the pain starts. So what happened? Then this has been ongoing for years. Why the pain now? The pain is because there have been a labral tear. Labral tears are quite painful conditions. The causes are likely to be trauma on the background of femoroacetabular impingement. Capsular laxity is a particular cause, but these patients have got a big range of movement. Patients with Ehlers-Danlos syndrome, they're very difficult to treat and very challenging. On the other hand, hip dysplasia can be a reason for a labral tear. Now, some people might say, we understand that with a pincer deformity, with a socket that's oversized, that there is a labral tear, but why with acetabular dysplasia does that happen? I'll explain in the next slide. Degeneration is normally secondary to a labral tear, but they can happen simultaneously. Patients presenting with deep-seated groin pain, often with mechanical symptoms, catching and giving way, pain and sitting in a chair a long time. Somebody might say, I've been sat in my car for half an hour and I've got pain. The investigation of choice is MR arthrogram, and this is the most sensitive investigation. It will show you clearly the presence of dye between the acetabular wall and the labrum. And it will show you the other pathology. It will show you whether there is an elevated head-neck junction and increased alpha angle. It will show you whether there's a pincer deformity. It will guide you as regards, if you're doing a hip arthroscopy, what exactly to do. I've participated in the FATE trial as an assessor and an observer and recruiter. I'm very proud of that. It's a big trial that shows the benefits of hip arthroscopy in management of femoroacetabular impingement. The predisposing factors of labral tears. So Wenger et al. 2004 found that 87% of patients with a labral tear had some underlying pathology. Now, acetabular dysplasia in particular, I'm going to explain why they predispose to labral tears. With the acetabular dysplasia, there's normally an oversized labrum, and because of marginal loading, that can result in the tear. The labrum is very important. Acetabular dysplasia, it helps, it compensates for the lack of acetabular cover and helps with the containment of the femoral head. This explains why patients with acetabular dysplasia can grow up to 17, 18, sometimes late 20s with no pain, and all of a sudden there's pain. And sometimes when there's pain and labral tear with acetabular dysplasia, patient starts complaining of micro subluxation or micro instability of the hip, and might show as lateral displacement of the femoral head. So let's talk about management of femoroacetabular impingement. Femoroacetabular impingement is all about assessing patient symptoms and progress. If the patient is improving and with activity modification and managing the pain, there might be no need to do anything more. Once you've damaged the labrum, there's a higher chance the patient will develop arthritis. You don't interfere because you're going to prevent something happening from later on. You never know what's going to happen later on. You assess the patient's symptoms at that stage and see whether the patient's symptoms can be improved at that stage of their life. Diagnosis, as I said, is through an MR arthrogram where it identifies the labral tear and other contributing pathology. What happens if there's underlying arthritis or cartilage damage? Then we have to consider how much damage there is. If there's significant damage, if it's not marginal, then there's no point in trying to treat your labral tear. This patient have already developed arthritis. the chances of satisfaction with the hip arthroscopy and labral repair is low. You have to consider that this patient needs to be managed symptomatically up to a point where they will need a hip replacement. It's reasonable to consider a diagnostic injection with these patients. One injection of cortisone under image guidance is not going to massively damage their chances of having a subsequent repair, but it will help you have a diagnostic tool to say that this pain is coming from the labrum, is coming from the hip, and therefore that's what I'm going to attack, and that's what I'm going to do. And if you're going to do a hip arthroscopy, you're not only going to do a labral repair, you're going to debride whatever pincer lesion or cam lesion with the labral repair, and then you're decreasing the chances of the labral tear to recur. Let's talk a minute about ligament injuries out there. The extra-articular ligaments are very strong, and even if they're injured, it's the diagnosis of exclusion. If you can't find anything, it's called a strained hip. They normally recover very well. These ligaments have got excellent blood supply, and even if you do a lateral approach and you open the capsule and they regenerate very well, there's nothing that we need to do particularly to them. On the other hand, the round ligament is not that strong. It doesn't regenerate that well. It's normally formed of 3 fascicles, and it arises from the transverse acetabular ligament and certain the fovea capitis. It also arises from the adjoining parts of the ischium and pubis. It may play a role. The role of the round ligament is not very well understood. It says that researchers say it might provide a role in nociception and coordination of movement. It definitely has a role in vascular supply of the femoral head in pediatric population, but up to a certain age, up to the age of 6, and then there is little progress from that. Some people compare the round ligament to the ACL with the difference. Of course, the ACL is much more important. If there is an injury to the round ligament, almost invariably there will be an injury to the labrum and articular cartilage. Hip instability. There's 2 types of hip instability. Frank instability, whether you do a plain radiograph or a standing radiograph, and you find that Shenton's line is broken with an increased joint space medially, or the micro instability with a hip that's perfectly normal on the plain X-ray, but the patient feels there is a degree of instability or lateral movement. With acetabular dysplasia, you can see that the loading is mostly medial, with the center of the head, center edge angle is much decreased. Okay, so in terms of management of instability with acetabular dysplasia, periacetabular osteotomy is a much more stronger tool than trying to repair the labrum, and this is what you should consider if the patient is symptomatic enough and have no arthritis. Can we give the patient instability? Yes, there is a number of cases reported after hip arthroscopy, particularly without capsular repair. And Jung et al. In 2016 have reported these cases, the sum of all cases, with most of the cases the instability was anteriorly, and it was secondary to hip arthroscopy without capsular repair. Other contributing factors was lack of capsular repair. Iliopsoas release, although it is seemingly a very innocent thing to do, iliopsoas release can sometimes lead to anterior instability. Female patients are more prone, and of course patients with acetabular dysplasia. Greater trochanter pain syndrome is another cause of patients presenting with hip pain. It has got a incidence of 1.8, almost 2 per 1,000. So it's a rare disease, but I have seen personally many of these cases. The pain is usually dull aching pain on the lateral aspect of the hip. It's aggravated by lying on that side. It's aggravated by resisted hip abduction and weight bearing. The pain is usually on the lateral side of the hip, as I've said, and the investigation of choice is through an ultrasound scan, where the ultrasound scan identifies an enlarged bursa, and MRI scan can show other pathology as well. The management is usually through an injection to that region, When you're injecting that region, there's two layers of resistance, the skin and the iliotibial band, and the bursa is usually next to the bone. A good response from the injection indicates that you are in the right place, and therefore you can consider what is your next step. Your next step is likely to be a bursectomy, whether that's open or arthroscopic. If there is any bony prominences or calcification, you can consider debridement. In refractory cases with evidence of iliotibial band tightness, your next step is a Z-plasty of the iliotibial band. The results of such procedures are never guaranteed 100%, and the improvement is somewhere between 70 and 80%, which is a good chance, but you have to explain that to the patient. If there's refractory cases and the patient is not improving, you must consider whether there is anything amiss, whether there is a problem with the gluteal insertion in the form of a tendinopathy. Tendonopathy or tendinosis or tendonitis are all synonyms, and the pathology is linked to collagen degeneration, local inflammatory process with inflammatory cell infiltration, collagen fiber disorientation, increased ground substance, and neovascularization. This is the total of the pathological findings in inflamed insertional tendinopathies. Etiology is repeat trauma and high stresses. The following tendons can all be site of such inflammatory process: the gluteus medius and minimus, the iliopsoas tendon, hamstring origins, and the adductor tendons. The gluteal tendinopathy is clinically associated with trochanteric pain, and it can show a positive Ober test, Trendelenburg gait, positive Trendelenburg test. It can progress to complete abductor deficiency, particularly if treated with repeat steroid injections. Be careful about the amount of steroid to inject to these patients. One injection for diagnostic reason and therapeutic is good, but repeating them too often can carry the risk of tendon failure. It could also be associated with hip arthroplasty. Diagnosis is MRI scan or ultrasound scan. Features can be identifiable on plain radiography with calcification in the distal tendon, which is very close to the appearances of calcific tendonitis of the supraspinatus. Management is management of pain. Steroid injections. There's also the platelet-rich plasma injection, which have got very promising results. Micropuncture or needling has been showing also promising results. For PRP injections, bear in mind that when you are having a blood sample centrifuging it to get the PRP, that have to be done in a sterile manner. The processing technique used by the lab is not suitable to take it back and inject unless you've got a sterile container. A single intratendinous PRP injection have shown that it has better value in the short term and the long term other than a cortisone injection. The injection is normally carried out under ultrasound guidance. Under ultrasound guidance can identify the areas of neovascularization and inflammation. You can target these areas with the injection. And as I said, that the effect has proved better than the cortisone injection at 6 weeks and up to 2 years. What about the iliopsoas tendon? It's very difficult to diagnose. It's like something that is really difficult, really tricky, because the iliopsoas tendon is so deep. It can be associated with hip replacement, can be associated with cemented hips, where some cement have escaped anteriorly to the bed of the iliopsoas, and it has been witnessed with uncemented hips with this cementless socket impinging on the tendon. Clinically, the Ludloff sign was pain on the groin when attempting to do a straight leg raise, but also pain on extension of the hip when the patient lies supine or hangs his leg off the edge of the bed can cause pain in the iliopsoas tendon. Imaging, you can get an MRI scan which confirms your doubts. And a CT-guided injection is a very good diagnostic test. You can't really identify the iliopsoas tendon with the ultrasound scan. Well, you can, it's rather difficult. But the injection is aimed at the bed of the iliopsoas tendon, which is identified within this fossa here. Hamstring tendonopathy is also more common in athletes. Deep ischial pain, pain on sitting, and increase on exercise. MR is the diagnostic investigation of choice. Management is usually through physiotherapy, stretching exercise. A diagnostic injection is very tricky because you're talking about you're going very close to the neurovascular bundle. The sciatic nerve is just in front of you. So you have to have some form of guiding your injection, ultrasound guidance. PRP injections have been used in these situations. Debridement and reinsertion is not something I've done before, but it is described in the literature. Now, this is a concept that not many people know of, tears of the hip rotator cuff. We all know of the shoulder rotator cuff, but many authors have referred to the muscles around the hip as the hip rotator cuff. Let's look about the similarities. This is a table from Dom et al. 2010. So as an internal rotator, you've got your subscapularis of the shoulder, you got your iliopsoas, which is mainly a flexor, that we don't really consider it as internal rotator. Your abductors are the supraspinatus and infraspinatus. We've got your gluteus medius. These are the stabilizers. With the deltoid is replaced by the tensor fasciae latae. Clinical presentation is same for both: pain with motion and tenderness, weakness in abduction. The diagnosis is normally through MRI and ultrasound scan. The mechanism is degenerative tearing or acute trauma. Arthroscopic evaluation is easier with the shoulder because you go inside the shoulder joint and you can see the shoulder from within, particularly with the pasta type lesion, the partial articular sided lesions, you can see easily from inside the shoulder. You can't really do the same for the hip muscles and the abductors. Gluteus medius tears are common in past, particularly in elderly patients. Now, I have witnessed many times while doing a hemiarthroplasty, going in, finding an oval type of fenestration, the abductors, and in some patients, I opened the iliotibial band to find a completely bald greater trochanter. These are particularly difficult situations because you worry about the stability of your hemiarthroplasty. They clinically present with lateral hip pain and pain and resistant abduction. That is particularly the case with partial tears. With complete tears, you quite often get a Trendelenburg gait. The gluteus medius tendons may occur in as many 25% of late middle-aged women and 10% of men. This is very relevant. It's more relevant than what we think. These tears could be intrasubstance, could be partial, could be complete. And Connell have shown that the partial tears were far more common. And with partial tears, the common ones are the deep portion of the muscle. So basically, if you're trying to operate on them, you might open the iliotibial band to find that the superficial layer is intact and the tear is actually deep. You have to identify those through an MRI scan. This is a schematic presentation of the insertions of the gluteus medius and minimus. For the minimus, it's just one facet and it's mainly anterior. For the medius, is three facets: anterior, superior, posterior, and posterior. With the most important fibers are inserted in the middle. Bear in mind that when you're doing a hemiarthroplasty, doing a lateral approach, you're trying to get to the entry point of your hip. Make sure that you don't detach the most important fibers of your gluteus medius. This is the key to the stability of your hemiarthroplasty. Bruce et al. In 2007 described a technique to repair the gluteal tendons. The technique is pretty much like repairing the rotator cuff of the shoulder, with debridement of the ends of the tendon, debridement of the insertion or the footprint, and then using anchors to repair them. All the patients involved in the research have improved their symptoms. And you can also, you've got a described procedure done arthroscopically with the patient's supine. It's a three-portal technique with the debridement of the ends of the torn tendon, the debridement of the bony bed, and then anchors and sutures, and they are repaired as such. So there's very, very similar to the appearances that you can see in a shoulder arthroscopy. What about long-standing and neglected cases? Retraction of the gluteus medius tendon precludes a tension-free repair. And if you find on MRI scan that the muscle belly is infiltrated with fat, then you can't really do anything about that. And this is also very similar to the MRI classification of supraspinatus tears, where retracted tears beyond the glenoid or showing fatty infiltration are not amenable to repair, and therefore you need to consider alternatives. It's very lucky that we don't see this very common, but nevertheless, the researchers have described a tendon transfer where they've used the superficial fibers of the gluteus maximus plus or minus the tensor fasciae lata as a tendon transfer technique. What about other conditions mimicking hip pain? We've got the snapping hip syndrome, Gilmore's groin, Piriformis Syndrome, sacroiliitis, Osteitis Pubis, neoplastic conditions, osteomyelitis, referred pain, and neuralgia paresthetica. For the sake of the discussion today, we will not be able to discuss all those. We're not going to discuss neoplastic conditions because that's a very broad topic. We're not going to discuss osteomyelitis because that's also a very broad topic, but we're going to briefly discuss the others and mention how to treat them. Snapping hip syndrome, there's a number of described snapping hip syndromes. This syndrome refers to snapping of the hip with movement and notably hip flexion. Only a third of people who have got a snapping hip has pain along, and we should never consider treating anyone who does not have pain because the treatment is mainly symptomatic and is aimed at pain. The snapping could be intra-articular, extra-articular. Intra-articular could be due to a loose body or a torn ligamentum teres. Extra-articular snapping is most commonly related to the tensor fasciae lata and the iliotibial band snapping across the greater trochanter with internal and external rotation. Medial snapping can be related to the iliopsoas tendon and iliopsoas precisa and irritation. Iliopsoas pain complicating hip replacement is generally developed as a result of cement extrusion. That's what we mentioned before. And if the patient gets good response from a steroid injection to the bed of the iliopsoas, then perhaps you can consider the next step to be an iliopsoas release. Another important topic is Gilmore's hernia. This is a small subclinical hernia, and it's caused by tearing of the posterior inguinal wall, as well as the general oblique aponeurosis and conjoint tendon with dehiscence. These are difficult to detect clinically, and quite often the clinical detection is through an ultrasound scan, it's a dynamic ultrasound scan. And once we diagnose one of those, it's very reasonable to refer to one of our colleagues, general surgeons, and they can manage from that point onwards. Piriformis syndrome is a potential cause of posterior thigh pain with inflammation in the piriformis tendon. Most authors describe non-operative management for it, and there's been described an arthroscopic procedure for release of the tendon. You can inject it with cortisone, but bear in mind that there is a number of variations to the piriformis and the exit of the sciatic nerve, which is classically below the piriformis muscle. But I remember the first time I was doing a posterior approach for a hip replacement and have seen the nerve emerging from within the fibers of the piriformis. And I was really worried that if the repair doesn't heal, that the retraction of the muscle can cause a sciatic nerve problem. These are rare occurrences, but nevertheless is very important, particularly if you're considering releasing the piriformis. And therefore, those who do an arthroscopic release must be very experienced in that procedure. Saco-lliac pain is another condition that is very important, quite often reduced to the buttock, and it can overlap quite significantly with hip pain. The capsule of the Saco-lliac joint is relatively very thin, but it's enforced by a very strong interosseous ligament, and the spino-lumbar ligaments are very important. The joint mobility changes with age. Normally, when a younger patient have got flat joint surfaces, but then bony elevations and depressions give more stability as people grow up. some patients above 50 have got already ankylosis. Bear in mind that if you see a patient and you diagnose them with sacroiliac pain, you need to consider referring to a rheumatologist. Ankylosing spondylitis usually present first with sacroiliac pain, and offering a patient steroid injection would not be the first line of management. First line of management is to investigate this patient for ankylosing spondylitis. Bear in mind that I've seen quite in a few occasions infections of the sacro-iliac joint secondary to steroid injection. These are very unpleasant situations, and you need to consider first if there is a medical management before considering injections or any other surgical management. Osteitis pubis is another condition which is very poorly understood. The origin is debated. Some people consider it as a result of pelvic instability. Repetitive trauma is definitely one of the reasons. Almost invariably, every patient I've seen with osteitis pubis was a weightlifter. There is no surgical management as such. You can consider a steroid injection. It's one of the most irritating conditions to treat. It's usually long-term, and there's very few solutions for it. That's the end of my presentation today. Thank you, Dr. Mohammed, and I hope what I've said today would be of help to you in your practice, everyone.
Thank you so much دكتور ايمن بيه. يعني احنا يعني متشكرين على المحاضره الاكثر من رائعه دي يا دكتور ايمن بيه. حضرتك كنت بتقول ان هي اكسبكتد ان هي تبقى اقل من محاضرات حضرتك السابقه، ولكن اي ثينك ان دي اعلى من المحاضرات السابقه يا فندم.
ربنا يخليك يا فندم.
المحاضرات كلها حضرتك والتوكس بتاع حضرتك كلها ما شاء الله يعني سوبر فانتاستيك ما شاء الله. وهو ده حضرتك اتس ا فيري امبورتنت ايتم السوفت تيشو انجري في اراوند ذا هيب. يعني من اعتقد من 10 سنين او من اكثر ما كانش حد يسمع حاجه عن فيمورو استابلر امبنجمنت، ما كانش حاجه بيبوت ان مايند. انا كان ليا توك في الكورس من حوالي 3 4 اشهر كده برضه على الفيمورو استابلر امبنجمنت، ودلوقتي I have to put in mind السوفت تيشو افكشن اوف ذا هيب يعني as much as البوني افكشن يا فندم. ده very important topic يا فندم.
اكيد. والسوفت تيشو مانجمنت حتى in the course of a hip replacement is very important. It affects the outcome massively.
تمام. يعني احنا هنبدا الدسكشن مع سعادتك وانا مستني الكويستشنز. سعادتك ايه راي حضرتك في الرول اوف التراسونوجرافي في السوفت تيشو دايجنوزس السوفت تيشو افكشن دايجنوزس اراوند ذا هيد؟
Ultrasound is very important, and particularly if cases of tendonitis, يعني Gluteal tendonitis can be diagnosed with ultrasound guidance. Trochanteric bursitis is very important, and I rarely do in my practice injections in clinic. I normally refer them to my radiologist colleagues. They do the injections themselves under ultrasound guidance. It helps to have a document to say that the injection went into the right place. Is very important medico-legally, and this normally even better place because they can see the inflammation and neovascularization, and then with the newer ultrasound machines, and they can target these with the injection. So it has numerous implications. It's all about seeking the training from the radiologist, and it's always about collaboration. You need to discuss with your radiologist colleagues and say this can be done, how the means to acquire the experience and then to do.
Yes sir. بالنسبه للهيب انجكشن او اسبيريشن حضرتك if I do it from the anterior portal I have to be guided by ultrasound، ولكن في اللاترال بورتال حضرتك بتستعمل ultrasound برضو ولا ما بتستعملوش فندم؟
For the lateral injections, I use ultrasound. Actually, if I'm injecting or aspirating the hip joint from anterior, I use fluoroscopic assisted guidance. So I use an X-ray machine because it's once I inject anteriorly, if I'm injecting the hip joint doing like a image guided injection, I just use the radiographic dye to make sure that it has spread along the head neck junction. Then I know I'm inside the capsule.
Yes, sir. We have one question, sir. Iliopsoas tendinotomy during arthroscopic labral repair problems post-operative, and any operative repair of iliopsoas post-operatively.
I don't know of many people who do a routine iliopsoas tendinotomy with hip arthroscopy. I think if you've got a pathology in the iliopsoas tendon and you've had a diagnostic injection and the injection was successful, and you think that the iliopsoas release will help, you can do that arthroscopically. You can do that as an open procedure, and it's likely to work if you've had a good response from a diagnostic injection. But I'm not aware of anyone who does a routine iliopsoas tenotomy as part of arthroscopy.
Yes, sir. Another question from Dr. Muhammad Wael Sadaka. Does adductor tenotomy has a role in chronic tendonitis and resistant pain, especially sports saucer?
As any other tendon around the hip, if you've got an adductor tendonitis, you can consider number one, diagnostic injection, whether that's clinical guided or ultrasound guided. If you've got refractory patients, you can consider an MRI scan to see whether there is any additional pathology. Always consider referred pain in these patients. Consider whether there's something else that you can't see. In particular, if you do a diagnostic injection, it doesn't give you the kind of relief that you've hoped for, you must consider whether the pain is coming from somewhere else. And if the diagnostic injection helped the patient with recurring pain, you can consider indeed a tenotomy, but I've not yet had to do a tenotomy for inflammation as such. I've had to do a tenotomy with hip replacement because of an extreme spasm of the adductors causing the hip to be unstable, but not for inflammation as such.
We have another question, sir. What do you think, sir, about the treatment of iliopsoas scarring post-arthroscopic hip surgery?
That becomes very difficult. Any scarring after arthroscopy is a problem. I've seen all sorts of scarring after hip arthroscopy. I've seen bony bars form along the arthroscopic track. It becomes really difficult to treat. Going back with arthroscopy, trying to excise scar tissue, you've got a high chance of that recurring. Sometimes it's better just to wait and try with physical therapy or try an injection and see how things go. But if things are refractory to treatment, then you will have to go in, but you will have to explain to your patient that you can't promise them any golden results. You can say to the patient that we'll try again, but I can't promise you that we will succeed, because these are difficult cases to treat.
Yes, sir. Any other question to Dr. Ayman? I don't have any other questions, sir. هو في النهاية احنا بنشكر حضرتك شكر جزيل دكتور أيمن بيه. احنا قطعنا اجازتك وعطلنا حضرتك، ونتمنى لك سفر وعودة ان شاء الله سيف جيرني لانجلترا ان شاء الله. ربنا يحميك ويحفظك دكتور أيمن بيه. وحضرتك يعني بصراحة من اول ما ابتدينا الكورس وحضرتك من الكورنر ستونز معانا في الكورس يعني بصراحة. فاحنا بنشكر حضرتك شكر جزيل على السبورت اللي حضرتك عامله لنا دكتور أيمن.
في حد عايز يسأل سؤال تاني؟
Any other questions? في واحد عايز يسأل سؤال تاني. Can you please write the questions?
لا ده حد بيقول many thanks بس.
لا في واحد raised his hand فجايز بيكتب السؤال.
محمد وائل صدقة. شكرين يا فندم.
دكتور محمد وائل صدقة من سوريا، هو من الإخوة الأفاضل من سوريا اللي معانا في الكورس على طول بصراحة يعني.
سلامنا لكل الأخوة في سوريا وسلامنا لسوريا.
الله يخليك يا فندم. احنا ان شاء الله يعني في السكند بارت اوف ذا كورس اللي هو الكيس بيس ديسكشن، احنا فاضل لنا الهيب. الاسبوع الجاي ان شاء الله في معانا حوالي 5 سبيكرز هيبقوا هيعرضوا حالات في انجريز اراوند ذا هيب والني والفوت اند انكل. وبعد كده زي ما كنا لسه بنقول لدكتور ايمن بيه هنبدا في مشروع كبير جدا ان شاء الله اللي هو السبيشاليتي دايز. انا كنت لسه بكلم جمعيه جراحه العظام فيه دكتور جمال بيه ودكتور عادل بيه. فان شاء الله السبيشاليتي دايز هتبقى كل حوالي، احنا هنستمر في المحاضرات بتاعتنا عادي في الكورس، انما كل اسبوعين او 3 اسابيع هيبقى في 2 دايز خميس وجمعه هيبقوا سبيشاليتي داي. السبيشاليتي داي ده هيبقى يوم سباين، يوم هيب، يوم بلفس. ده هيبقى حاجه على مستوى ان شاء الله عالي جدا. ان شاء الله هيبقى في ليكتشرز من ناشونال وانترناشونال ايميننت سبيكرز، هيبقى في كيس بيس ديسكشن، هيبقى في لايف سيرجري، هيبقى في كادافيريك ورك شوبس ترانسميتد من الكادافيريك لاب في ميونخ، وهيبقى في ورك شوبس على موديلز، كل ده، وهيبقى في لايف سيرجري، كل ده في 2 days discussing all the topics of this سبيشاليتي. فان شاء الله ده هيبقى مشروع كبير جدا بنبدا نجهز له من دلوقتي، وربنا ان شاء الله يسهل ويساعدنا ان شاء الله باذن الله. وطبعا وجود دكتور ايمن بيه معانا ان شاء الله هيساعد كتير باذن الله. دكتور ايمن بيه
محمد وبراي،
ربنا يخليك يا فندم، شكرا جزيلا يا فندم، وان شاء الله have a nice trip and safe return ان شاء الله to England ان شاء الله يا دكتور ايمن.
باذن الله.
Thank you so much. تصبحوا على الف خير يا فندم. شكرا دكتور ايمن بيه. تصبحوا على الف خير يا فندم.